So this is the second time that I've been invited to talk to this group, and I want to thank AIM and Dr. Kirkwood for allowing me to come speak with you. AIM is, I was on their website late last night. I'm a procrastinator, so excuse me. But AIM is, what a great website, what a great resource with all of the past symposiums since 2011, lots of speakers, lots of really world-renowned melanoma speakers from all over the country talking about updates and treatment and options for patients with melanoma. So AIM is a very commendable and wonderful organization, so thank you again. For surgeons, we have always traditionally been somewhat of proceduralists. So working at the University of Pittsburgh, I get to surround myself with very intelligent people. Dr. Kirkwood, Dr. Tauby, Dr. Ferris. So I, by osmosis, hopefully become a little bit more intelligent and a little bit less of just a proceduralist. But what I'm going to go over today is really the surgical management and the procedures we perform for melanoma. There's not going to be a huge amount of science in my talk, and it is simplified for the rationale as to why we do what we do in the operating room. There's a lot of questions the patients have when they come to my office. Why are you cutting me here? Why are you cutting me there? Why does it have to be so long? So I just want to go over why we do things, so maybe it'll make a little bit more sense. Many of you have either gone through melanoma, have family members with melanoma. So a lot of what I talk about, you're probably going to already know. So this is just a little bit of a reinforcement. In addition, I apologize, there's some overlap between Dr. Ferris's slides and my slides. I was also charged with talking about staging. Surgery and staging go hand in hand. It's very difficult to get the stage of a disease process, specifically a melanoma, unless we have surgery to identify the depth of the melanoma or the nodal status of the melanoma. So when I talk about one, I talk about the other. So the goals of surgery are, one, to identify whether or not a mole is a melanoma or not a melanoma. Two, to gain the accurate microstaging of that melanoma, depth, ulceration, mitoses, and I'll go over those as we talk further. Appropriate margins to decrease the likelihood of local recurrence, optimal function and outcome and results. So we want to do a surgery that removes the melanoma, decreases the likelihood of coming back to almost zero without deforming somebody or making somebody's extremity or body part dysfunctional, and then checking whether or not there's any nodal disease. So you saw this on Dr. Ferris's discussion. You present to your physician or your primary care doctor or your dermatologist identifies a lesion that is concerning, that fits one of the A, B, C, D, E, F, G, all of the different letters. So what do we do for that? So it needs to be biopsied. We need to look at that piece of tissue underneath a microscope. So there's a couple of different ways. An excisional biopsy is usually what's mostly performed in dermatologist's office and is probably the best way of looking at the melanoma. So you do a 1 to 2 millimeter margin circumferentially around the tumor, remove the tumor down to below where the tumor invades into, and send that off to the pathologist so they can give us a diagnosis. For an extremity, we really want to make it in the longitudinal direction so that when we go back to do a resection, we could do a more narrow resection than if you go transverse, we have to do a much wider resection. So always keeping in mind that there might be a further surgery and try to make it easier to do that further surgery. If the lesion is bigger and more difficult to take out in the office, maybe too big to take out in somebody's primary care office, it's better to do a punch biopsy. So it's a circular razor or circular scalpel, and you just pass it down through the side of the tumor, usually at the junction between the normal skin and the tumor, and then use a scalpel or scissors to cut the base of it and take that piece of tissue and send that off. You haven't removed the entire tumor, but you've facilitated the ability to diagnose it, and if it is a melanoma, then get it to the right person to do the right type of resection. So that tissue will then go to the pathologist, and the pathologist will create this type of report. It's a lot of words. But when Dr. Kirkwood and Dr. Taubey and I look at this pathology specimen or pathology report, we're looking at some 4 specific things within this report. Is it a melanoma? Yes or no? What is the depth of that melanoma? Is that melanoma ulcerated or not ulcerated? And is there active cells dividing within that melanoma? The reason that we're looking for the depth is that'll help us with staging. Ulceration usually tells us that the cells are growing more rapidly than other types of melanoma, and that makes it a little bit more worrisome. In addition, mitoses also tells us the number of cells that are dividing. Usually if we see cells dividing, that makes us a little bit more concerned that this is something that might be growing a little bit more rapidly. So we want to treat these a little bit more aggressively. So again, just going over what Dr. Ferris looked at, this is T staging of the TNM classification, tumor, nodes, and metastases. So this is just looking at the primary tumor. So stage 1 is less than 1 millimeter in depth. We believe that as the tumor grows deeper into the tissue, it has more access to the lymphatics in the blood supply and therefore can spread more easily. So a more superficial tumor usually has less of a chance to spread and can more easily be treated and cured. Stage 1B is where the tumor grows past 1 millimeter up to 2 millimeters or is 1 millimeter and has ulceration. So that ulceration we talked about now upstages a more superficial tumor to a higher classification. Stage 2A goes up to 4 millimeters or up to 2 millimeters with ulcer. Stage 2B, greater than 4 millimeters or up to 4 millimeters with an ulcer. And then stage 2C is greater than 4 millimeters with ulceration. So we get that pathology report. It tells us that it's a melanoma. It tells us the depth of that melanoma. And now we need to plan our surgery as to how are we going to get local control of that melanoma. We're going to stop it from coming back at that one particular site. So we need to plan our definitive treatment. We need the excision to be wide enough that it won't come back and deep enough down to the muscle layer so that it won't come back. We don't have to take out muscle unless it's invading the muscle, which is incredibly rarely. We usually just go down to the muscle, leave the muscle intact. And then I will go over the margins. The nice thing is that over the last couple of decades, we've been able to identify that surgeons have always thought bigger is always better. So we would go really, really wide on our resections, except that cosmetically and functionally, our outcomes were poor. So there's been a lot of research in multiple institutions in multiple countries looking at more narrow margins on primary melanomas and whether or not that increases local recurrence rates. And luckily, we've been able to prove that more narrow margins are just as good as wider margins up to a point. So in the past, we used to do very big resections. We would have to do flap closures, rhomboid flap closures, big tissue transfer closures, and again, cosmetically not as pleasing. On the left, there's a skin graft versus on the right, where we do more narrow margins and we can get a straight line. And again, cosmetically and functionally, it's a little bit more pleasing and a little bit more functional. So thin melanomas are classified up to 2 millimeter thickness. Recommendations for 1 millimeter lesions and less. So they used to do 5 centimeter margins, which is quite a large piece of tissue. Multiple studies looked at doing 2 centimeter margins versus 5 centimeter margins, and they found that the local recurrence rates are the same, low single digits. So we realized that we didn't have to do 5 centimeter margins, we could do 2 centimeter margins. And then other groups looked at doing 1 centimeter margins versus 3 centimeter margins. And they identified that 1 centimeter margins are the same as 3 centimeter margins. So 2 is equal to 5, 1 is equal to 3. So for 1 millimeter of depth melanomas, we could do 1 centimeter margins, which is a very straightforward way of taking off a piece of skin. And almost everywhere in the body, face, ankles, all the areas that are tight, we can get tissue back together, primary tissue back together. For 1 millimeter, 1.01 millimeter to 2 millimeter margin, they looked again at doing 2 centimeter margins versus 5, 1 versus 3. And there was a slight increase local recurrence rate in patients between 1.01 and 2 millimeters with 1 centimeter margins. So they say, we prefer you to do 2 centimeter margins, but if you have to get a better cosmetic or functional outcome, you could start to drift back towards 1 centimeter margins because the local recurrence rates is only increased by about 3%. So for up to 2 millimeter thickness melanomas, we can still do 1 centimeter margins if it's in an area that you have to. We prefer 2 centimeter margins. For intermediate thickness melanomas, which is 2 millimeters to 4 millimeters, we do 2 centimeter margins. 2 centimeters was equal to 4 centimeters, therefore we do 2 centimeter margins. When they looked at 1 centimeter margins, it was definitely a higher local recurrence rate, and therefore 2 centimeter margins anywhere in the body is preferred. Thick melanomas, greater than 4 millimeters, these are T4 lesions. We still only do 2 centimeter margins for these deeper melanomas because overall outcome and survival is not necessarily based on local recurrence. It's probably more based on metastatic disease because as you get deeper, you're much, much more likely to have spread. And therefore, if we do a big local surgery, we're still going to end up really focusing on your nodal status and your metastatic, possibly metastatic disease. So doing a big cosmetic surgery is not necessarily going to change your overall outcome. So again, we focus just on 2 centimeter margins for 4 millimeters or greater. So that is local control. We're just resecting that local disease process. And in the thinner melanomas, just local control is a cure because the likelihood of spread is very, very low. As you get deeper, there's a much higher chance that there's spread, and we need to know whether or not there's spread. There's no other test other than biopsying or sampling those lymph nodes to give us that nodal status. So, and melanoma often metastasizes through the lymphatics first. So usually we can identify nodal disease before we could identify any other disease. In addition, here and in many other academic centers, nodal status, we use nodal status as a prognostic indicator. So people who have nodal metastases have a higher likelihood of having disease recur. And because you have a higher likelihood of disease recurring, you would benefit more from adjuvant treatments, from protective or preventative treatments that Dr. Kirkwood will offer you. So we need to know whether or not you're at that higher risk. We'd like to avoid giving you adjuvant treatments or treatments that might make you sicker if your disease process is very unlikely to come back. So we don't want to make you sick when we're not necessarily going to help you. So we want to know the patients that have a higher likelihood of coming back, and therefore we offer you further treatment. Physical examination, unfortunately, is not enough. It's often inaccurate. Body habituses make it difficult to identify lymph nodes. We don't necessarily know where all these lymph nodes are going to go, what lymph nodes they're going, melanoma's going to go. So we don't know which basins to focus on. And there's a 20% node negative, which will have microscopic disease. And even if you palpate lymph node disease, 20% of those patients underneath the microscope will not have metastatic disease. So just being able to feel a lymph node or just being able to not feel a lymph node doesn't necessarily prove to us yes or no whether or not there's nodal disease. So back to the staging. So stages 1 and 2 are based on tissue depth with no evidence nodal metastases. Stage 3 disease is where now we're finding microscopic and macroscopic lymph node disease. Stage 4 disease is when there's metastatic disease. So when we're doing our lymph node sampling, what we're looking for is to see if you are stage 3 disease. And again, we use lymph node status as a prognostic indicator. So based on stage, overall survival decreases as you go further up in stage. So we want to see what stage you are so we can give you an accurate prognostic evaluation. And now with the 2010 update to the TNM classifications, we could break it down even further into the likelihood of overall survival at 10, 15, and 20 years based on just the depth of your tumor and based on the microscopic versus macroscopic, or more lymph nodes versus less lymph nodes. So again, it's the rationale as to why we do a stepwise progression of evaluation of tissue to put you in the accurate stage so we could give you an accurate prognosis. So sentinel lymph node biopsy. So like Dr. Kirkwood said, in 1992, out of California, they were working with injecting particles locally around a primary tumor, both melanoma and breast, and looking to see if these particles would follow the lymphatics to a lymph node. And if they would, could we evaluate that lymph node and see if there's any evidence of spread? Now, it's based on the rationale that there is a specific orderly pattern of lymphatic drainage, meaning if we injected stuff, it would go to a lymph node. If we waited and we injected again a couple of days later, it would go to that same lymph node. So we would believe that the melanoma cells, if they were going to spread, would go to that lymph node first. The second idea is that lymph node is a filter. It would hold on to those tumor cells. So just because it went through the lymphatics to the lymph node, we need to know that it's going to stop at that lymph node, and if we take out the lymph node, we could look at that lymph node and find those cells. The third idea is that if that lymph node is negative, what's the likelihood of the surrounding lymph nodes being positive and we just accidentally missed it? And hopefully, if this works, this was the idea in the late 80s, hopefully if this worked, we could avoid further surgeries where we're doing more exploratory lymph node dissections just to look for disease, because in the vast majority of times it was negative, but we were doing bigger surgeries and surgeries with potential side effects in patients that didn't necessarily need it. So here's just a schematic of a patient with an abdominal melanoma. They injected, in this picture, blue dye. Here we do a lot of radioactive labeled dye. 4 spots within 1 centimeter of the primary melanoma, and then look to see which lymph nodes it goes to. So it follows these paths to this sentinel lymph node. And hopefully it would get stuck in this lymph node, and we would identify that nothing passed to the other lymph nodes. So in the initial studies, they looked and they injected radioactive labeling and or blue dye, and they went and they dissected out that sentinel lymph node. After they took out the sentinel lymph node and sent that to the pathologist, they went and completed that local axillary or inguinal lymph node dissection, removing the rest of the lymph nodes to make sure that we weren't missing something. In the initial studies, they identified that 75 to 90% of the time they were able to find that sentinel lymph node. And in addition, only 1 to 2% of the time when they did the completion dissection was there any disease that was not in the sentinel lymph node but was found in other lymph nodes. So in the vast majority of the times, if you find that sentinel lymph node and it is negative, it's not going to be in the remaining lymph nodes. As we got better over time, it's now about 15, 20 years since we've been doing it, it's 97 to 98% of the time we're able to find that sentinel lymph node. And so almost everybody who comes here for a sentinel lymph node biopsy, we find that sentinel lymph node. Unfortunately, there's still a false negativity to this. So in the years after we do a sentinel lymph node, there's still a 4 to 10% chance that even though we find a negative sentinel lymph node, at some point there might be disease that shows up in that lymph node basin. But in the vast majority of the people that we identified a negative sentinel lymph node, we could avoid any further surgery. So what's the likelihood of detecting metastatic disease in those lymph nodes? So here, Dr. Kirkwood and I always talk about the rule of tens. So 10 times the depth gives us the likelihood of whether or not there's any disease in that lymph node. So if you have a 1.2 millimeter depth melanoma, probably a 12% chance of being in that lymph node. As you get increased depth, increased percentage chance of being in that lymph node. So on average, less than 1 millimeter in depth, only 4% chance. 1 to 2 millimeters in depth, 12% chance. 2 to 4 millimeters in depth, 28% chance. And greater than 4 millimeters, a 44% chance. Again, sentinel lymph node biopsies is a prognostic tool, and just looking at overall disease-free survival rates at 5 years after a sentinel lymph node biopsy for an intermediate thickness melanoma. If your sentinel lymph node is negative, there's an 83.2% chance overall of being disease-free at 5 years versus only a 50-ish% chance if your sentinel lymph node is positive. So again, that's the rationale as to why we want to go in to do that sentinel lymph node biopsy. On the flip side, melanoma-specific 5-year mortality is significantly higher if your sentinel lymph node is positive versus if your sentinel lymph node is negative. And again, this is the rationale as to why we want to treat those people that have sentinel lymph node positive disease with some of our adjuvant treatments and adjuvant protocols. It is the single most important factor predicting melanoma recurrence. So the procedure. So oftentimes I'll meet you in the office, we'll talk about the procedure, we'll plan a date, we'll do the paperwork, and then you come in the morning of surgery and you go to nuclear medicine. In nuclear medicine, they'll inject some radioactive particles right next to the tumor, and they'll do a lymphoscintigraphy. And this is a lymphoscintigraphy. So this is a patient of mine that had a mid-chest melanoma. They injected 4 aliquots of radioactive material here, and you could see it following along the lymphatic channels, going out to 2 lymph nodes in the left axilla and 1 lymph node in the right axilla. You then come up to the operating room, I meet you, we talk about what we found at the lymphoscintigraphy, and we take you to the operating room. I use a neoprobe, or a fancy Geiger counter, and I use that to identify that radioactivity within that nodal basin. I make a small incision over that radioactive area, dissect down to that lymph node, remove it, close things back up. The surgery usually takes about an hour, and most people go home that day, no drains. So here is the axillary incision for that patient. Very small, not cosmetically terrible. It's in an armpit, so most people aren't concerned about their armpits. So as this was one of the newer therapies within surgical management of melanoma, surgeons started to use it on everybody. Everybody who presented with a melanoma was getting sentinel lymph node biopsies. The problem is that in the really thin classification of melanoma, the likelihood of there being a lymph node positivity is so low. Should we be doing the surgery on patients with a 0.02 millimeter melanoma when their likelihood is less than 2% chance that their lymph node is going to be positive? So the American Society of Clinical Oncology, which is the medical oncology group, and the Society of Surgical Oncologists got together and decided to make a guidelines as to who should get sentinel lymph node biopsies. So sentinel lymph node biopsies should only be done on people with 1 millimeter depth melanomas or greater, because that's a 10% chance of being positive or greater, or if it's less than 1 millimeter and has some of the worrisome findings like elevated mitoses or ulceration. Once we do the sentinel lymph node biopsy, if the sentinel lymph node biopsy is negative, no more surgical workup. If the sentinel lymph node biopsy is positive, then we will proceed to a completion axillary or completion inguinal lymph node dissection so that we can get an accurate number of lymph nodes that are positive. Again, as you look at the classifications of nodal status, as you got higher lymph node status, recurrence rates increased, and therefore prognosis decreases. So we want to know that so we can accurately treat you. So in summary, if you find a worrisome lesion, please have it looked at by a medical professional. Have a low likelihood for a low threshold to biopsy any concerning lesions. If the melanoma is 1 millimeter or less with no worrisome features, we could do a 1 centimeter margin excision and no sentinel lymph node is necessary. If the melanoma is greater than 1 millimeter or has any worrisome features, then we want to do a 2 centimeter margin and get a sentinel lymph node biopsy for staging and prognostic purposes. And if sentinel lymph node is positive, a completion axillary lymph node dissection is warranted. Thank you very much.